Okay, we're going to move into ectopic pregnancies. This is where a pregnancy, a fertilized egg has implanted somewhere besides the uterus. Usually the most common place is going to be in the fallopian tubes, and then it's called a tubal pregnancy. These are non-viable pregnancies. A mom cannot carry a baby full term if the baby has implanted outside of the uterus. Signs and symptoms can be abdominal pain, delayed menses, spotting at 6 to 8 weeks, after a normal period. If the uterine tube ruptures, there will be shoulder pain with inspiration, like showing that there's internal hemorrhage somewhere. Possible complications leading to infertility, especially if those fallopian tubes are getting damaged because the fertilized egg has to travel down those. And like I said, it's a non-viable fetus. Care management. One medication that they'll use in the early detection of a fetal tubal pregnancy is something called methotrexate. This is a chemotherapy drug, so it is out of scope of practice for LPNs to use, but it does work to dissolve cells from a tubal pregnancy. So it's a non-surgical option if caught early. All right, here's some just pictures that are showing like in an ectopic pregnancy. So the pregnancy will join somewhere other than in the uterus. It could be by the cervix, it could be in the fallopian tubes, or just inside where those two things connect, the fallopian tubes and the uterus. Here's miscarriage. So threatened pregnancy, the fetus is still alive and viable, but there's some bleeding. Inevitable is a lot of blood loss, and the tissue's actually starting to separate from the uterine wall. And then incomplete would be some of the tissues are left behind. Here's a complete expulsion that the tissues in the fetus have come out altogether. And then a miscarriage is when there's no bleeding or anything. It's just the fetus has passed away, but the body has not let it go yet. And sometimes that process has to kind of be prompted. All right, going to talk about placenta previa and placenta abruption. So placenta previa this is where the placenta is implanted partially over or completely over the cervix. So that piece of tissue that is there to help keep the baby alive actually is implanted right over the cervix. A sign and symptom is painless, bright red bleeding, and it's diagnosed by ultrasound. Complications can be hemorrhage, fetal death, or need of a hysterectomy. They're going to need a C-section due to the risk for hemorrhaging and fetal complications. So if the fetus, if during labor and delivery the cervix is starting to dilate, then that means that the placenta has to start breaking away. Well, that's the way the baby gets perfusion. So you don't want the placenta coming out before the baby, or detaching before the baby comes out or is ready to come out. Placenta abruption, this is where the placenta is being ripped away from the uterine wall. So this is an emergency issue. The sign and symptom with this one is painful vaginal bleeding. You got to think of a scab being ripped away from something. So abdominal tenderness, contractions, firm board-like uterus. It's going to be super firm because there's blood building up. Complications, fetal death, hypovolemia, and hysterectomy. Going to need an IV for replacement of fluids, induction, if there is a partial placenta abruption, and then may need an emergency C-section. So again, here's some pictures. Here's the abruption. You can see this one is a hemorrhage, like an internal one. You wouldn't see bleeding from that one, but there would be pain in that board-like uterus. This one you would have some bleeding, and this one is complete separation and definitely have some bleeding of the placenta. Here's a picture of a placenta previa. So here's where the placenta is partially covering that cervical os, or that opening, and here's where the placenta, that total where it's all the way covering the cervix. Bleeding incompatibility. So Rh negative blood is an autosomal recessive trait. So Rh positive blood is a dominant trait in women, and Rh incompatibility can occur if a woman has Rh negative blood and the fetus is Rh positive. So maternal blood is going to be tested. They'd like to know what dad's blood type is as well. But generally, if mom has a negative blood type, they're going to go through with a lot of testing and then the RhoGAM shots, just because Well, sometimes things happen and moms might not always be honest about who the father is, that kind of thing. It gets sticky. So if dad has a negative blood type and mom has a negative blood type, then the fetus should have a negative blood type. Now, if the dad is a positive blood type, then there is a chance that the baby will also have a positive blood type. And then that's where the mom's antibodies are going to start attacking the fetus. Whoops, I didn't mean to hit that. Oh, shoot. I've lost my spot. Okay. So, substance abuse in pregnancy. This affects both mother and fetus. So if mom is going to take an illicit drug, baby is also. Becomes concentrated in the amniotic fluid also. There is a table in your book, table 5.9, for different effects of different substances. Okay, labor and birth process and nursing care. So the process of labor is moving the fetus, placenta, and membranes out of the uterus through the birth canal. So lightening, these are things that precede labor. So lightening or dropping, which is when the fetal head descends into the pelvis during the third trimester, so getting closer. Return of urinary frequency because of that pressure of the head on mom's bladder. Stronger Braxton Hicks, those practice contractions are getting stronger. Weight loss due to hormonal changes. Surge of energy, like that nesting period. This is where the mom gets the need to like clean everything in the house, Bloody show is a sign that the cervix is starting to change. Cervical ripening, the cervix is starting to get softer. And then possible rupture of membranes. Rupture of membranes would be the water breaking. So here's kind of a picture. I'm not even sure if this is the same person, but it does show like, here's the baby that is not down into the pelvis as much. And then here's a baby that you can definitely see has gone down and very far into the pelvis, and why that would put pressure on a mom's bladder. First stage of labor lasts from onset of regular uterine contractions to full dilation of cervix. This stage lasts longer than 2 and 3 combined. Lots of variability, anywhere from days to weeks. There's 3 phases. Sorry, I didn't mean to go. 3 phases to that first stage. So latent phase is effacement without descent. And then effacement is the shortening and thinning of that cervix. Active phase is the rapid dilation of that cervix. And then transition phase is increased rate of descent into the birth canal. So here's a picture. I know I showed this in lab. So effacement, this is that cervix thinning. It's that, I showed that video of the balloon with the ping pong ball. So the neck of the balloon getting shorter and then the hole getting wider. All right, so true labor, this is where contractions are regular. So they're coming at equal intervals, getting stronger, lasting longer, and becoming more frequent. Okay, so those are true contractions. And then it's got to be like a wave-like motion over the entire belly, not just in certain areas like Braxton Hicks are. The cervix, a vaginal exam would show progression, softening, effacement, and dilation, and possibly bloody show if the cervix is changing. And then it moves from that posterior position to an anterior position. So I talked about this in lab, how the cervix is like more towards the back of the mom, and then during labor, then the cervix kind of moves to the front of mom. Fetus becomes engaged in the pelvis, which increases the ease of breathing. So moms can breathe easier with this, but then it also increases urinary frequency. All right, false labor. So the contractions are irregular or temporary or only in certain places in the abdomen and not like the downward wave over the whole uterus. Cervix vaginal exam shows no significant change. Fetus presenting part is not engaged, so it's not fully in the pelvis. All right, rupture of membranes. They'll do a test to see if that's really amniotic fluid. It could be other vaginal discharge or even urine. So they'll test it. If it's more acidic, that means the membranes are probably still intact. If it's more alkaline, then the membranes have probably ruptured. There are some psychosocial factors that need to go into labor and delivery, especially memories of sexual abuse or being restrained can come out during these like high intense, hormonally driven times in a woman's life. So we want to wait and be conscientious of what we're saying. We don't want to say it will only hurt a little or please open your legs. And then we want to make sure we're asking permission before touching. Stress, how much support or past experiences or horror stories have you heard? That allows for time for questions and things like that, especially those first-time moms. They've probably heard a whole bunch of horror stories, and some of them might not even be true, and the nurse can help work the patient through those stories. Cultural factors, sense of failure or disappointment may have unusual risks like taking the placenta home or requesting a squatting position during delivery. Those things are kind of normal. We do not, in the hospital setting, allow moms to take the placenta home, though. All right, nursing considerations during labor, vaginal examinations, checking for cervical changes and status of the membranes. So baseline needed upon admission. Exams need to be done with sterile gloves, and lubrication should be infrequent as possible to minimize the risk of infection, right? Because the nurse or the examining person's hand has to go through a pretty dirty area into that sterile environment of, where the baby is at, past that cervix. So being mindful that we don't want to keep doing those checks because that's going to increase the risk for infection. Often uncomfortable until epidural often uncomfortable until epidural or anterior position of the cervix. So when moms are being checked, when we're looking to see that cervix and baby's positioning and things like that through a vaginal exam, it's extremely uncomfortable until that epidural that can help with pain management or that cervix really moves to an anterior position. Amniotomy is the rupture of membranes done by a physician using a plastic amni hook, which is right there, or a clamp. So this is kind of starting to become old news, but some places still follow this. I'm going to say on your NCLEX, it's probably going to follow this yet, but there's a window of 24 hours after the rupture of membranes. Could be artificial or spontaneous, that baby needs to come out because the risk of infection and that infection causing negative consequences just significantly increases as time goes on. And so if the baby has not been delivered vaginally within 24 hours, they're often going to take mom and baby to a C-section to get baby out. Keep linens clean and use and change out chucks frequently, especially if the water has been broken, because every time there's a contraction, it seems like more amniotic fluid is going to be coming out. Second stage of labor lasts from when the cervix is fully dilated to the birth of the fetus. So there's two phases to this stage. There's the latent, which is the passive descent through the birth canal. We call this laboring down. So this is where the cervix is like fully dilated, but the head is just not coming down fully yet. And this could take like an hour or so. The urge to push may not be strong. Then the active phase is when moms have a strong urge to push or bear down. So if they have an epidural, they might not completely feel the need to push, and so they'll get they'll get really uncomfortable, really sick almost, and then that's when they get checked, and if the baby's head's far enough down, or maybe they're feeling super uncomfortable with contraction, doctor tells them, let's just try pushing during this next contraction, and if the mom feels better during that pushing, then maybe that's what we're into. We need to have that active stage of labor and that strong urge to push. All right, strong signs of onset of second stage, that urge to push or have a bowel movement. There could be appearance of sweat on the upper lip, episode of vomiting. That is so common. Those hormones, I tell you what, increased bloody show that cervix is really changing, shaking of extremities, and like my teeth were always chattering, during this time I couldn't, stop shaking. Increased restlessness and involuntary bearing down efforts. Active pushing help to change position and encourage bearing down efforts, help to provide relaxation and conserve energy between contractions, provide comfort and pain relief measures. Cleanse perineum properly if fecal material is expelled. As baby's moving through, it could be pushing some fecal matter out as well. Coach to pant during contractions. We want to increase that perfusion, gently push between contractions if needed to. If head is emerging, provide emotional support, encouragement, positive reinforcement efforts, keeping the environment very positive and calm. Be informed of progress. They always want to know, okay, is the head out? Is there hair? Things like that. That always kind of helps move the process along. And then create a calm, quiet environment and offer a mirror to watch the birth is also a common thing. All right, hopefully we'll only have one more recording after this.